All right, well, we're just going to get going unless I hear or see, I don't know where the text box is. So I'm just going blindly. What am I doing?
We can hear you.
I'm going clicker happy. I apologize. Can everybody see the screen? It says chapter 16, clinical exam.
Yeah.
Okay, thank you. All right, we'll just keep on going. All right, so as you know, with the periodontal exam, ideally we're doing this for each and every patient at the start of each new appointment, as we do in clinic. Now, when you get into private practice, you might not have the time to do a complete periodontal assessment on every patient every time. Your office protocol might be once every 6 months, once a year, depending on what the periodontal status is. Some offices will also alternate radiographs, one appointment, and perio assessment, another appointment, depending on what the recare assessment is. But screening is essential at each and every appointment. Even though you're not doing a comprehensive written down examination, you still need to examine all the spots. So what's the rationale for periodontal assessment? It does provide a baseline for the long-term monitoring of the periodontal disease activity. For new patients, it's critical to have that baseline. And you also want to measure your outcomes to evaluate the success or failure of your treatment. What worked? What didn't work? What sites are still inflamed? And then you need to determine what's going on there as well. And then periodontal assessment can be done many times during the year. It depends on what the patient's protocol is, depending on what's going on in their mouth. So what we're trying to do is intercept something before the disease process actually begins, which is primary prevention. We want to keep things healthy, and the only way we know how to do that right now is through certain examinations. So assessment of the damage to periodontal tissues is one of the things that we're measuring. We want to look for changes to the gingival connective tissue attachment. Those are where the collagen fibers are. The junctional epithelium, is it still where it's supposed to be, as well as the alveolar and supporting bone. We do take radiographs, and radiographs, as you know, is a historical perspective on what's already happened. So we want to check the health or disease of the patient, and the hallmarks that we use are periodontal probing as well as radiographs. So we want to determine the periodontal disease activity. And activity means it's the stage of the disease characterized by ongoing loss of connective tissue attachment and alveolar bone. Now that is quite different from having an infection. Periodontal disease is an infectious process, but the patient can be stabilized for a long period of time without active disease. So we have to kind of look at the disease and activity as two different things. Periodontal probing and radiographs, again, are the retrospective views of the disease activity. And it's difficult to determine current disease activity if a periodontal site is actually breaking down or will break down in the future. We do know that if you have had past periodontal disease, then the likelihood of getting future disease is much greater than if you've never had disease. So ongoing disease is periodontal disease activity. Active perio means you are experiencing breakdown versus active infection, okay? Two different things. And that was something that I had to wrap my head around when I was a graduate dental hygienist, because that wasn't the philosophy when I was going to school. If you were bleeding, you had infection, you had disease, you had activity, you had ongoing disease. It was going to get worse and you were going to lose your teeth and die. That's just the way we learned it. So the most commonly used screening device is measuring with a periodontal probe. We're looking at the depth of the gingival crevice as well as the clinical attachment level. And this allows you to make presumptions about the health of the periodontium. So you've seen this picture dozens and dozens of times. You want to know where the junctional epithelium is. You know the gingival fibers, which connect the neck of the gingiva around the tooth, the periodontal ligament fibers, the PDL, as well as the alveolar bone. When you're measuring, you want less than 20 grams of pressure. 10 is ideal, but you're looking for where the base of that junctional epithelium is. What are some of the limitations of probing? Clinical probing depth can be noted and may be greater than the histological probing depth due to the penetration of the inflamed tissue. If you've got edema, swelling, the tissues are inflamed, you are going to have more of a buoyancy at the base of the gingival sulcus or pocket. So depending on what pressure you've got can determine plus or minus that 1 millimeter that we give each other. So factors include the force used. Are you a heavy-handed prober or a light-handed prober? The size of the probe as well. If you've got something very thin, almost like an explorer, you're going to be able to get farther in tighter tissue than if you've got a big, fat probe. The placement and angulation, again, is critical, as well as the type of probe used. And the tooth anatomy. Can you move around the bulges and the depressions adequately? So again, this is why we give ourselves that plus or minus 1 millimeter. So if you are struggling with, is it 2.5 or 3? I don't know. It's a 3. Just move, round up, move on. Because if we get a 2 and you get a 3, it's essentially the same thing. So disease progression is what we're looking at, and it's important in determining what the past periodontal disease activity was to help predict what the future activity will be, because we do know past breakdown, as I said, has a higher likelihood of future breakdown. So the distance from the gingival margin to the base of the probable crevice. Okay, so histologically, you've got the tip of the probe that goes into that junctional epithelium, and it's a little bit buoyant, so it doesn't just stay on top. It bounces just a little bit. And the probing is the clinical approximation of the soft tissue attachment to the tooth. So it's of clinical importance for the periodontal pockets in that they are the major habitants of the periodontal pathogens. The deeper the pocket, the more likelihood that the bacteria is not being disrupted, and they are becoming from aerobic gram-positive and transferring to the anaerobic gram-negative. So it's good for identifying areas that are potentially therapeutic problems on a site-by-site basis, because we do know it is a site-by-site basis. You could have infection on the mesial portion of the tooth, and yet the distal portion of the tooth can still be healthy. So again, these are just pictures from the textbook that will show you the differences between A, which is a normal, healthy sulcus depth, right? And then you've got B, which is the attachment here for the clinical attachment that is below the CEJ. So it depends on how far below the CEJ, whether or not there's clinical attachment loss or not. Then C is the apical point of the epithelial attachment, again, below the CEJ. You've got the bottom of the sulcus, and you have then apical migration. So look at where the bone is, and this is where some students get confused. The bone is normally, okay, where this F and E is normally about 2 millimeters beyond the CEJ. So when you're looking at clinical attachment level and clinical attachment loss, that bone is not supposed to be right at the CEJ. So when you're looking at the new AAP classifications and it's telling you what that CAL is, 1 to 2 millimeters, 2 to 4 millimeters, 3 to 4 millimeters, you're already taking that 1 to 2 millimeters into account. That bone, the crustal bone, is below that CEJ, and from there you're looking at the clinical attachment loss. Okay, so clinical attachment level, clinical attachment loss is CAL. Many of the books consider them synonymous, and it's not. Clinical attachment level is where the attachment is, and you can be in complete health and have a clinical attachment level. It's not until you end up with that apical migration of that junctional epithelium that you have clinical attachment loss. So it's quite confusing because of that. But the CAL, the clinical attachment level, is the distance from the CEJ, which is your stationary landmark, to the base of the probable depth. And it's a clinical approximation of the soft tissue attachment to the tooth, which is the junctional epithelium. And it's more reliable than measuring probing depths because the probing depths can change as they migrate apically. The gingival tissue can go along with it, that marginal gingival tissue, but that CEJ is always stationary. So that's why we're looking at that CEJ as the standard of where we start measuring. They do have some wonderful probes that have been out for a number of years now that help the consistency and reliability, and they're used in certain areas of the country more than others, as well as in studies that are done. But there are automated pressure sensitive probes. They are connected to a computer and they automatically record things for you. So you are not calling out the 323, 323, 212, that type of thing. The disadvantage is that there is loss of tactile sensation because of the type of probe that it is. And there's no clear advantage that's been shown that this is any increase in accuracy of the periodontal condition that the patient has. But when you are working unassisted, boy, does it help. There is a slight learning curve. This is an example of the Florida probe, which is one of the first ones that came out, and it was a computerized program. You can see that it looks very similar to the Dentrix or EagleSoft. Perio charting is a Perio charting. They also have this little box up here on the upper right for a PSR, periodontal screening and recording. And we've talked about that a little bit, where you've got a specific probe with a ball at the end, and it looks like a color-coded probe. There's a black band from 3.5 to 5.5 millimeters, and you just do sextant by sextant. You're probing all the areas of that one sextant, and you're just recording one number for that sextant. So a 1 and a 2 means everything's within normal limits. A 3 and a 4 means it's into that 3.5 to 5.5 band, or covering the band, depending on if it's a 3 or a 4. And then you've got your star or your asterisk and other things to denote if there's roughness, calculus, bleeding, and that type of thing. So what the periodontal screening and recording does is it allows you to determine very quickly with just 6 numbers what areas of the mouth require further investigation. And this was developed by the World Health Organization because so many patients were going undiagnosed that they came up with something quick, easy, simple to use that everybody could use. And then the ADA and the AAP got on board because, again, this was one of the things that hygienists and offices were getting sued for, was not diagnosing periodontal disease. I kind of like this chart because I'm visual, and it's got the PSR, and at the bottom you can see that it's got the plaque sites as well. So you're able to do a plaque score on the form itself, and it also gives you a summary I used to do this manually because I never had one of these, but we would count up, and I made a little chart. You know, I kind of morphed all of the periodontal charts that I've come in contact with into my hybrid. This was a Betsy chart that I incorporated into my treatment, but I would have the number of 4mm sites, 5mm sites, 6mm sites, 7 and above, and the number of bleeding points. And there'd be a little table up on the top of the perio chart so that when we did this time and time again with patients, we could compare the amount of healing or infection that's taken place. Because if the patient went from 32, 4 and 5mm sites down to 13, we could then compliment the patient saying, look how many millimeters of resolution that you've had. So it's just a nice broad thing. Another periodontal charting here that is more in a table form. This means nothing to me, but it does have the recession and the furcation, mobility, that type of thing to get you more information. So we talked just a little bit about the PSR. Now the board loves asking questions about the PSR, and every year the students come going, I forgot what the PSR was. Well, this is what it is. Again, it was developed by the World Health Organization and accepted by the ADA and AAP. The PSR indicates when a more comprehensive exam should be performed. My problem with this when I went from perio to a general practice who was using the PSR was that I want to know if 5 mesial is a site that continually bleeds. Is it 5 mesial? Because all you know when you've got that one recorded number for that sextant is there was a bleeding site or more in that sextant. So I'm not a fan of PSR, but it's better than nothing. Again, the mouth is divided up into 6 sections, so you've got 6 areas, and if you just have one area that has a 3 or a 4, that shows it needs further investigation or a more comprehensive exam. The idea was you're only doing that comprehensive exam on that one sextant, again, to save the clinician time. And my philosophy was, no, we don't do it this way. So you've got 6 measurements that are recorded around each tooth. That is on a normal. On the PSR, you have 6 measurements, but you're only writing down one category. Most clinical errors occur in the interproximal readings. Are you standing up your probe? Are you angling it too much? It's that type of thing. One office that was in the development I was working in a number of years ago had a consultant, a hygiene consultant, come in, and they were telling the hygienist to not upright the probe because they would then be able to get 1 to 2 millimeters greater in depth, and they would then be able to sell more scaling and root planing and perio programs. So that is, again, one of the errors of interproximal readings. So we will be checking your probing each and every patient that comes in. That's part of the perio assessment that the instructor, until the day you graduate, will always be checking. Now, your doctor, when you're in private practice, isn't going to be checking. They will go in and check, spot check sometimes as part of their regular exam, or you will be calling out the specific areas that you want them to investigate. You know, does the patient, are you recommending some further treatment for that particular patient? But as you know, you're making small walking strokes of about 1 millimeter, and you're bobbing up and down and up and down. You're staying in that pocket the entire time. You are angling the probe interproximally to get to the center of that caul area, and then you're straightening up the probe as much as you can. This is a Williams marking probe, and they don't have any black lines on them. These are the type of probes that I had when I was a student, and oh boy, did that make it hard to read. So now you've got nice little black lines in there. If you're over angling the probe, now I've done this a couple of times, especially with perio patients because they don't have a great architecture, and sometimes this probe here will not hit the other side of the caul, but it'll come all the way out this way, and that's when you're going, oh my gosh, they've got a 15mm pocket. That's when you go in and you recheck your technique. So this is more in line of the type of probes that we see now. This again is a Williams marking probe where you've got 1, 2, 3. Then the next line is 5, 7, 8, 9. So that's the Williams probe. We're using a UNC probe where it's 1, 2, 3, and then you've got a thicker black line for 4 and 5, and then it goes up from there. So it's always nice to have the same probe in every packet, in every operatory, so you don't have to be guessing at, now which probe is this? Is this the 4mm line or the 5mm line? It just makes life go that much faster. So is there bleeding or is there not bleeding? The presence of bleeding oftentimes indicates there's inflammation in the connective tissue, the lining of the sulcus or the pocket, and they have an ulcerated epithelium. So we're always looking at bleeding on probing, and we're also quantifying the type of bleeding. Is it immediate? Is it a gusher? Is it slight oozing? Is it delayed? Because that can give you also some sort of an understanding of how inflamed is that pocket area. But that only tells us that there's inflammation. Again, it doesn't tell us that there's disease activity. Is there ongoing attachment loss, or is it just inflammation? So that's one reason why we have to have that baseline for all of our patients, so we have something to compare it to. Deep probing depths and bleeding on probing may indicate disease activity. Doesn't mean that they are continually losing attachment, but we know they have disease present. So we've got these calibrated probes that can be used to make two types of measurements. We're measuring the probing depths, and we're determining the clinical attachment level to see if there is attachment loss. So we've got, as you know, different types of pockets. We've got a gingival pocket and a periodontal pocket. A gingival pocket is a pocket that still has intact periodontium. We call it a pseudo pocket. So if you're getting 4 and 5, even maybe a 6mm probing, it doesn't mean that they are automatically a perio 2 or they've had attachment loss. You have to see where that CEJ is in relation to the marginal gingiva and where the bone is in relation to that CEJ. So it could be what we call a pseudo pocket, where the attachment is where it's supposed to be, but everything is just puffy and inflamed. And you can't see me, but my hands are going all over the place. Then you've got your periodontal pocket, where there is clinical attachment loss or apical migration of the junctional epithelium. You've got your suprabony as well as infrabony pocketing. The clinical attachment loss, now that's a pathological destruction of the gingival fibers with apical migration of the junctional epithelium along the root structure. So just know what these words are, because number one, you're in a perio class, and number two, you're going to get tested on this in your perio class, and number three, this is on the boards. This is just hallmark. It's apical migration of that junctional epithelium. Detection of disease changes that may indicate disease progression is 2 to 3 millimeters in change measurement, because we give that 1 millimeter plus or minus even between you're probing one time and you're probing another time, or you're probing this time and I'm going in and checking immediately after. There's that plus or minus 1 millimeter. So we're looking at changes of 2 millimeters or more. And then if there is, we then need to determine, is it an active site or an inactive site just with infection? So we're looking at here the probing depth versus the clinical attachment level. The probing depth is the distance from the free gingival margin to the attached gingival tissue, right? And depending on where that attachment is will give us that CAL. When the free gingival margin is apical to the CEJ, like this particular picture on this premolar, you want to add the amount of recession. So you've got 3 millimeters of recession with 2 millimeter probing depth. So the CAL is 5 millimeters. So if the gingival margin was at the CEJ, which would be about where the normal is, at or right above the CEJ, you could be measuring a 5 millimeter pocket, which is beyond what that normal depth would be. You can also see right here the depth of the probe, the tissue's translucent, and you can see where that junctional epithelium is. So you want to compare that, as well as, is there a mucogingival defect? Now, in your periodontal probing, math-wise, it might look that there's a defect because it's 0 millimeters or whatever, but you also want to go in and take a look at the suspicious areas to see where the probe tip is in relation to that junctional epithelium to determine if it's a true mucogingival defect or just a wannabe, like something that you need to keep your eyes on. So the probing depth versus the clinical attachment level. You can see that this area has a pocket to it. This is a lateral incisor. The probing depth is the distance from the free gingival margin to the attached gingival tissues. The clinical attachment level is the distance from the CEJ to the attached gingival tissue. When the free gingival margin is coronal, okay, if there's gingival overgrowth, the distance to the CEJ is subtracted, but that's usually, we don't do that very often unless it is a severe case. This, that CEJ is, say, 2 millimeters below, okay, so for that, they may be probing 4 millimeters or 5 millimeters. Then if the CEJ is 2 millimeters from there, you're going to subtract 2 from the 5 to give you a more accurate CAL for that particular tooth. But if this gingival margin is at or just slightly above the CEJ for our purposes with Dentrix, we are considering that the normal level and it's a 0. So the probing depth again versus the clinical attachment level here. When the free gingival margin's at the CEJ, we don't need to add or subtract anything. So the probing depth is that clinical attachment level. Again, it's CAL until we know there's apical migration to that junctional epithelium. Then it's CAL for loss versus level. So we're looking at where that gingival margin is. Where's the actual level? Or where's the apparent level? The apparent level is also, where is that free gingival margin? Is it above the CEJ or below the CEJ? If it's above the CEJ, we have some subtracting to do. And also, is it a hidden recession or visible recession? Hidden recession is a pocket, connective tissue loss, but the CEJ, I'm sorry, but the gingival margin is still at the CEJ. So that's hidden recession. So it really depends on what literature you're reading. So where's the position of the gingival margin? Normally it's just about a 0.5 millimeter above the CEJ, and we don't deal with 0.5 millimeters in perio unless we're doing research. So it's a 0.5 to 1 millimeter above. We consider that normal. Recession is if you can see the CEJ and it's apical to, the gingival margin is apical to the CEJ. So again, we have actual recession. You can see the CEJ. Then we have apparent recession, and that's when the probe measures from the free gingival margin to the CEJ. So that's like that hidden recession, all right? Then you've got your total recession, which is the clinical attachment level. So that's the actual recession. Where is the CEJ? Where is the gingival margin compared to that? You've got your visible recession. You can see where that CEJ is. That's the amount of recession plus the probing depth. You've got a pseudo pocket where the gingival margin is above the CEJ. So that is the probing depth minus the free gingival margin. And then you've got your free gingival margin. When it's at the CEJ, they equal each other. So we're really confusing and muddying the water here. But for a pseudo pocket, it's everything is above the CEJ. If the gingival margin is at or within a millimeter above the CEJ, we are considering that equal to the CAL. So what do probing depths not tell us? All right, this came from the your Gehrig text. Again, it's showing you hidden recession on tooth A versus visible recession on tooth B. But look at where the bone level is. It's still at 6 millimeters. Okay, so this is the 6 millimeter marking at the CEJ, and this is the 6 millimeter marking at the CEJ. So the CALs are really the same. Okay, this is a color-coded probe, 3, 6, 9, 12 millimeters. This is a yellow plastic probe, which is thicker than the metal probes. They're also called marquee probes, which are very thin. And that's what I ended up using in my perio practices because they were so thin. So we want to determine and record the probing depths, all right? And we're looking at those two slides. So the probing depth here is 6 millimeters. The probing depth here is what? That would be 4 millimeters because it's above the 3, okay? It would be 4, you could round up to 5, but it's really about a 4. So does either A or B have more bone loss than the other? They're the same, they are identical, but the probe depth is completely different. So this is why we need to always know where that CAL is, because if I was just doing periodontal probing and I was getting 4 millimeters, I would think that that's not bad, but they really have a 6 millimeter defect. The bone levels are the same. The probing depth is 6 millimeters. The probing depth is 4 millimeters. Probing depths alone aren't telling us what we need to know. And this is something that a lot of practices do. They just do the periodontal probing depths. They don't measure other things. It's one of my beefs with the restorative clinic too. You get a restorative clinic patient, the patient's paid $150 for a comprehensive exam, which is 4 horizontal bite wings, a panorex, maybe a couple periapicals. They have periodontal probing, which is just the periodontal probing, no gingival margin, mucogingival lines, anything like that, and then they get a treatment plan written up. Well, anyway, that's all I'm going to say about that. So someone looking at the facial probing for tooth B would see a 4 millimeters, and if that's all they saw, again, that's not bad. We can deal with that, but they've already had bone loss. So the probing depth alone is not enough to tell us where that they are periodontally, because that gingival margin can swell as well. So probing depth readings accurately indicate the level of the bone only if the gingival margin is in its normal position or slightly above that, half a millimeter above the CEJ. So where's the level of the bone? If the gingival margin's not in the normal position, then we are looking at doing some calculations. We need to know what the probing depth is and the gingival margin. If it's at the CEJ, or if the gingival margin's at the CEJ or just a little bit above, we're considering that normal or neutral. If the gingival margin covers the CEJ, okay, we are doing some subtraction. If there is recession and we can see the CEJ, we're doing addition to come up with that CAL. So we've all seen the probing depths and then the gingival margin and then the CAL there. So each chart is going to have a slightly different way of expressing this. I don't even like where the gingival margin is on this particular chart, because look at the overgrowth on these mandibular anterior linguals. This is where the gingiva is supposed to be, way above the cingulum there. So your clinical attachment level, again, is not just where the periodontal probing is. It's the location of the periodontal attachment system to the tooth. It's also the estimated position of the structures that support the tooth as measured with the periodontal probe. Do we need to do calculations or not? But you are doing the CAL for each and every tooth. Dentrix and the other programs that are out in private practice will calculate the CAL automatically for you. We have taken that function away. So each of your computers, no matter what campus you're at, should have you calculating the CAL manually, because we want this just to be so ingrained in you that you understand it and you don't even have to think about it by the time you take your boards, because on your boards, they will be asking you to calculate CAL. And oftentimes you have to go searching through a case study. One of the students who took their boards said their periodontal probing did not have recession on it, on the chart like ours does, like the Dentrix has. They had to go into the pictures and other things to find where the recession was and then calculate the CAL. So they oftentimes don't make it easy on you either. Okay, normal level, gingival margin, you don't have any calculations to do. Recession, you are measuring the recession, CEJ, to the gingival margin, adding that to your probing depth to come up with your CAL. Gingival overgrowth, you're subtracting where the gingival margin is to where that CEJ is, and then your measurement, all right? Because you, again, that CEJ is your constant. So you're always looking at the CEJ. So on this picture, it says probing depths don't tell the story, and it doesn't, because you're going to have a 4 millimeter on the first picture, a 6 millimeter on the second picture, and an 8 millimeter on the third picture. Bone levels all the same. Now, this particular person here is more apt for root surface caries and a couple other things, but 4 millimeters is much more manageable for the patient to try and disrupt that bacteria than trying to reach 6 millimeters. And 8 millimeters, even though this part is just extra tissue, it's horrible to try and maintain an 8 millimeter area. So you've got to know how you calculate. And this is the same picture that we saw earlier. Now look at where the gingival margin is. They are saying there's 1 and 2 millimeters overgrowth. And look at this, number 25, there's 4 millimeters of gingival overgrowth. There was a 6 millimeter defect. Okay, they probed 6 millimeters. There's 4 millimeters of gingival overgrowth. You subtract the two, so the CAL is 2 millimeters. And we can practice that more if we need to, but you're going to be doing this with each and every one of your patients. So don't be afraid also to ask your clinical instructor when you finally get to see a patient again. We don't know when that's going to be, but when you finally get to see a patient again, we will help you with this. So it's okay to ask questions. You're a student. That's what we're here for. We don't yell. Well, I yell a little bit, but we try not to yell. Okay, so the clinical attachment level is the estimated position of the structures that support the tooth as measured with the periodontal probe. It is calculated to the estimate level of the periodontal attachment system on the tooth. So we need to know where the CEJ is, where the gingival margin is, as well as what the periodontal probing is. So gingival recession, is it visible or invisible? visible recession, you can see it. You see the CEJ, you see the root surface. Invisible recession, did I spell that correctly? Is where the gingival margin might be at the same level, but you're getting a pocket reading. That does not look right to me. So the etiology, okay, trauma to the tissue, disease process, surgery can oftentimes give you visible recession. Are there frenum pulls, malpositioned teeth? What type of habits do you have? This is generalized visible recession due to overzealous toothbrushing. And you can see the areas of abrasion here. Well, wouldn't you love to get an air powder polisher on that now? Gingival recession in refractory periodontitis. Now remember, refractory, we're not really using that as a special category. We used to have perio 1, 2, 3, 4, and then refractory. Any unresolved case can be refractory. So you can be refractory gingivitis if they're not responding to treatment. Gingival recession here is due to the disease process. And look at this mucogingival defect on this mandibular anterior tooth right here. Again, if you blow air here, that tissue is very friable. It will actually blow away from the tooth and you can see down to the attachment. You can see how red this is here. Okay, so how would you describe this gingiva? How would you describe this gingiva? It's not just all pink or all coral pink or red. Look how inflamed and shiny and red this is compared to over here. So they could be a generalized something and a localized something else. Okay, so this could be, you know, between 9 and 10. You're making a different description. Okay, it's rolled, it's glossy, it's purple or magenta compared to the other areas. What does that gingiva look like? Look at these clefts here. What are they caused by, do you think? They've got residual calculus. You can see this inflammation going all the way down. So is it papillary inflammation? Is it marginal inflammation? Or is it diffuse inflammation? And this is diffuse inflammation on the mandibular anteriors. It just encompasses the entire attachment apparatus. Coral pink, tightly adapted. You would think that would be the sign of health. Stippled. How would you describe this? Generalized attachment loss. We need to know where that mucogingival junction is. And that is the area that demarcates the movable mucosa from the attached gingiva. And we can't always see it by color differences. So sometimes you have to take a periodontal probe and kind of see what's movable and what's not. The nice thing about the physiologically pigmented gingiva is that you can see the demarcation lines, but some people that have thin red type of mucosa, very vascular attached gingiva, it can oftentimes look just like the free gingiva as well as the attached gingiva and the buccal mucosa. You can't demarcate things. So we need to be identifying that with their periodontal probe. This, you can see that there's visible recession. There's an amalgam restoration, which isn't being placed like this anymore because it's unsightly. But the nice thing about amalgam restorations is, especially before composites and isolation was so good, is that their chance of getting recurrent decay was much less than with the bonding techniques. But the probe reading here is, this is the 5 millimeter mark. So this is the 3 millimeter, 2 millimeters. So you've got 2 millimeter of a probing depth. Gee, that doesn't sound bad, does it? But look at where that gingival margin is compared to where that mucogingival line is. That's why you always want to look. So you could have a 2 millimeter probing depth with a 2 millimeter CAL here from the gingival margin to the mucogingival line and a 6 millimeter or 7 millimeter, whatever, and that is a mucogingival defect. This is the another type of probe. The probe I had in school was the Williams marking, and this is, I think, the Goldman Williams. It's, look how flat this is. So the flat surface, I don't see them in private practice, haven't for years and years, but it's nice for tight tissue on the straight buccal and straight lingual. You can't get interproximally with that. So we would have double-ended probes for that. And when you can't find where that alveolar mucosa is, where that mucogingival junction is, you can take your probe, lay it horizontally, and just see where it kind of pinches up. See where that movable gingiva is, and that's where you take your probe. This is gingival overgrowth, or delayed passive eruption is more like it. It's not gingival overgrowth. The teeth just, the gum tissues just never got beyond where that, remember that crust of curvature, which is near the CEJ? It's not exposing that crust of curvature. So what would they do today with something like this? For cosmetic dentists, they would recommend crown lengthening procedures, either through laser or electrosurge is what they used to do, and they'd literally just take and trim that excess gum tissue away. So if you had a gummy smile, that's one of the things they do. This is a crown that the patient evidently had for a number of years. You can see the difference not only in the translucency, but the color of it. It's longer than its predecessor. This is a composite restoration here. So for cosmetically, if this was a cosmetic dentist, they would recommend crown lengthening, trimming this gum tissue, maybe putting veneers, whitening and veneers, and redoing this crown. Now what they're also doing for the gummy smiles is they're putting Botox in on the upper lip, so that upper lip can't retract up towards the nose, and it just keeps that upper lip down a little bit so it covers some of that gummy smile. So we want to know what the total width of the gingiva is, right? And that's one of the measurements. And then we subtract where is the pocketing in relation to that. We want to know how much attached gingiva that patient has. We like seeing what we call a thick zone of attachment, because the more attachment there is around the tooth, if something goes wrong with the tooth, pocketing or whatever, there's more attachment still holding on to the tooth versus if the patient has a naturally thin attachment level. They don't have any of the natural defenses then. With if there's a millimeter of recession and they have only 2 millimeters of attachment, whether it's pathological or not, they're going to end up with a mucogingival defect very early on. Is there separation or is there not? Separation is pus. Whenever there's pus, you want to be investigating why. Is it because there's infection in the pocket? Is there something else going on, like a periodontal abscess or an endodontic abscess, something like that? Now, this is deep probing depths were noted. Wouldn't you love to just kind of squeeze and see what comes out of there? But you can also see a little bit of redness right here with 2 little bubbles. Is that an endo or a perio abscess or a combined? You'll need further investigation, and one of that would be a radiograph. You're checking for tooth mobility and fremitus. You're checking the patient's bite. Mobility we've gone into, okay? And it's not unheard of that after periodontal therapy that the patient has an increase in mobility, and then things start tightening up a little bit after that, especially with when there's occlusal discrepancies involved. We use the Miller's classification of mobility, +1, +2, +3, or plus. okay, depending on what your computer or office uses. Plus or a +1 is just slight vibrations can be felt. It's less than a millimeter. For example, the mandibular anterior, it's not uncommon to have just slight mobility, but if it's less than a millimeter, we don't usually record that. We shouldn't be seeing mobility in anything other than, say, the mandibular 4 central incisors. So know what your 1, 2, and 3 mobility are. You're checking for fremitus, which we've gone over. That's that tap, tap, tap with the finger. An open bite. Teeth are migrating due to bone loss. Is it pathological bone loss? You're checking for furcation involvements, and depending on what type of patients you've had so far, again, don't be afraid to ask for help when you're using your periodontal furcation probe, your neighbor's probe for the first time. You've never seen them before. You don't know how to use them. We are more than welcome and happy to help you. We love teaching, and I just saw another typo in there, and that was there last year. I'm sorry about that one, muckle. For the maxillary molars, you want to look for trifurcations. You're looking at the buccal, right, where you've got your buccal furcation, but then you're looking for your mesial and distal furcations as well. Those are your trifurcation areas, and that is going to be normally felt from the lingual aspect, because again, those embrasure spaces are broader on the lingual. And this is showing you that first premolar here. You can see this distal, or I'm sorry, the mesial depression going all the way up the root. Furcation involvement. Showing you probably a 1, 2. This is a 3. If the gingival margin is covering it. If the gingival margin is not covering it, it would be a 4. But you can see air on the other side of that. We use Glickmans. So it's the Millers for mobility, Glickman for furcation, grade. Okay, now remember, Miller's was a class, 1, 2, and 3. Glickman is a grade, 1, 2, 3, and 4. We use a neighbor's probe for grades 1, 2, 3, and 4. So a grade 1, no gross or radiographic evidence is evident. Now a grade 1, depending on what textbook, even though we're all talking about the Glickman, if we can't get our explorer to go into, to start dipping into that furcation, that roof or the crotch a little bit, we're still considering this a just a watch, okay? But it's a 1 if we can start getting it into the furcation. It's a 2 if interradicular bone is destroyed, and we can get it starting to go into the furcation more. And then a 3 is a through and through, and a 4 again is a through and through that has the that you can see. So we've got classifications of vertical bone loss. Now this is horizontal bone loss. Think about the pocket. We're looking at the crotch of the tooth or the roof of the tooth going from buccal to lingual, horizontal bone loss. But we're also measuring vertical bone loss, okay? And that's with your straight probe. So furcation is going to be how much can we get into this area. Then the grade of the furcation, A, B, or C, is how deep is the vertical pocket. So you've got your horizontal pocket, okay, which is the crotch or the roof of the furcation. Then you've got your vertical pocket as well. And this is just showing you how you can get into the furcation. This is the lingual here. It can slip in very nicely into the lingual. The palatal-gingival grooves of your maxillary incisors. Again, it's the maxillary lateral, which is most prominent. You want to make sure that you're really doing a slow walking, because this tissue in A doesn't look bad until you stick a probe in there. Each office, especially before we were standardized computers, had different perio charts that we would use. I particularly liked the one I developed because, again, I morphed everything. I took what I liked from probably 6 different perio charts and all the courses I went to and created my own. So as you know, we need to get a baseline on all of our patients, and probing depth is measured from the gingival margin to where that tip of the probe stops within the junctional epithelium. And every patient needs to have some sort of a baseline. Clinical attachment level is measured from the CEJ to the apical extent of the probe and is more accurate long-term measurement. So we're always looking at that. So it is, I've been on the computer now. Okay, so this didn't take us quite the amount of time I thought. So what we're going to do is get out of here. You're going to check your email for the next link, because I'm going to set up another Zoom meeting. Are there any questions? Okay, I'm going to stop the sharing.